Okay, you can just stand over here for now. We are going to work on humerus and shoulder today. So the difference with humerus and shoulder than what we've done so far is going to be that we're using the wall bucky, right? So when we're using the wall bucky, a couple of things come into play. We have to make sure that our tube is in detent, left to right, and then also that we're at 40 inches SID, okay? So detent, we've talked about this a little bit, is when you're in the little groove, okay? So you can hear it there. So when you fall into that groove, it becomes harder to move it left to right. When you're in detent, that means you're perfectly centered here, so you can't move your tube to line up on either shoulder. You have to move your patient, okay? So once you're in detent, we can't move left to right. And then for 40-inch SID, we bring our tube in. There is a light here that will light up when you get to 40. So right there, we're at 40. That's actually 38 to the front of this image receptor, or to the bucky, but then we have that 2 extra inches between the front of the bucky to the actual IR, okay? So, we pull this out. This is where our image receptor is gonna go. When we're using a 17 top to bottom, it just fits perfectly in here. But whenever we're using a smaller image receptor, we have this little shelf that's going to sit here to hold that image receptor centered. So when we get to the shoulder, we'll talk about that, okay? So let's go ahead and start with our humerus. So for humerus, we're going to use a 14 by 17 image receptor. It's going to be either lengthwise or portrait, right? Because our humerus is a long bone, not a wide bone. So it's going to come in here. You put this in here and kind of hold it with your hand, and then this latch, you push it in, and there's actually another clip on this side that holds it in place, okay? So whenever we put this in here, we push these together, it holds it centered in the image receptor, or in the bucky, and then you're going to push this clip, all right? We talked about our collimator and how it has a 40-inch line and a 72-inch line. So on the 40-inch line, you're going to set this at 14 side to side, 17 top to bottom, and now we know we can't make our collimation any bigger than that, okay? So Lauren's going to be my patient. Go ahead and put your back against the board here. We're going to look at the right humerus. So take a little step to the left for me. Now I'm gonna have my patient for an AP. I'm gonna bring this down a little bit. So we're centering mid-humerus, okay? So we want to make sure that we have light field above the shoulder, but then also below the elbow joint. So go ahead and turn your hand so the palm is out. Now with this, not only do we want the palm out, but we need to check to make sure the epicondyles are parallel with our image receptor, okay? So I had a bone where, thank you. For the humerus, when we're talking about parallel and perpendicular, it doesn't matter if the humerus itself is tilted this way. We just want to make sure that those epicondyles aren't turned left or right. We need them nice and straight, okay? So we're not necessarily talking about parallel like this, just as long as the epicondyles are in line with the image receptor. Okay, so my epicondyles are parallel. I have light field above and below. Now, once you have your light field centered on your patient where you want it, you're gonna push this little black button on the bucky, and we're gonna bring that down a little bit so that we're lined up, okay? You wanna put that laser in line with the black line, all right? And then the last step here is going to be to turn my collimator head this way so that I'm in line with her humerus. Make sense? Mm-hmm. Collimate side to side, because we don't need to see all of that. And then I can put this right marker here on the board in the light field, okay? Shielding, you are going to use the rolling shield. So we can just roll that over here in front of our patient. I always like to let them know not to trip over all the spider legs on there, okay? So that is our AP humerus. Palm out, humeral epicondyles parallel with the image receptor. We're centered mid-humerus, okay? The lateral, my patient's going to turn their arm so that the back of the hand is on the hip. So more like on the hip here. Good. take a little step to the left. Don't trip over the spider webs. All right, now, because of my patient having that bend in her arm, I'm actually going to raise my light field a little bit because now my elbow came up, right? So, right out there. Now I'm going to tilt this to match again. So I turned it straight before I moved it up or down. That way I could still realign, okay? So now I'm going to turn this to match. I'm able to see that my elbow shadow is here. I still have the top of the humerus here. And then we talked about making sure that the humerus is straight, right? We want to make sure that her elbow is not pushed back because then we're going to be foreshortened. So we want to make sure that the humerus itself is nice and straight, okay? So centered mid humerus, have that elbow bend. We can see that my elbow shadow is included. That's our lateral. Okay, so AP with the hand turned out, lateral with the back of the hand on the hip. Now, another way you can do a lateral humerus, I'm going to show you guys the left just because it's going to be easier because that's closest to you guys. But if you were to do this, make sure you do the proper arm, is PA. So for a PA, I'm going to have my patient just bring her hand across her stomach with the palm up and turn all the way around, but let's do your left arm. There you go. And then when she gets to this point, take a step to the right for me. And then I want you to put your whole arm against the image receptor. So she pushes her shoulder to the IR, bring her arm in a little bit. And so now we've eliminated all OID. So this way. Bring your arm with you then. Right there. Okay. We've eliminated all OID. I'm now seeing the elbow in a perfect lateral. And actually, I lied to you. Come back this way. So this is a PA lateral, okay? So hand across the stomach. And if you have a patient who really is injured or broken, they're going to have an easier time with this than this, okay? So hand across the stomach with the palm up. The reason for the palm up is we still want that lateral elbow perfectly positioned with the radius and the ulna. So palm up, her elbow is perfectly lateral. But now we've eliminated all the OID, and this is a lot easier for patients who actually are having a hard time, okay? For practicum, you can do it either way. Whatever way you feel is easiest for you, or easier for you to remember is fine. You can relax. But I will tell you, in the real world, that PA is going to be more common or easier for your patients to do than this, okay? And that's just because if you turn your arm in like that, you can feel your shoulder, like it doesn't feel great even for me. So, okay. That's humerus. And then we also have the transthoracic humerus. It will not be on the practicum, but I'll demonstrate that one really quickly. So my patient has a broken right humerus. She's going to put the right humerus to the board. Good. And then I'm going to have you step forward a little bit. So we want to center on the left humerus, okay? Because we're assuming, good Lord, that that's going to be in line with the right, okay? So then now that I'm centered there, I'm going to have her bring her left arm up and over her head. And we are shooting through her thorax to the image receptor of that right humerus, okay? The breathing instructions are that slow, deep breathing so that we can blur the ribs and the lungs, 3-second exposure, and we're seeing that humerus and able to evaluate the fracture, okay?
Still have culminated that close.
So, that's a good point. Step all the way back for me. I'm still at my 17 top to bottom. So you have to remember about your beam divergence, which I talked to the other lab group about. If you have a patient like how in that position we're that close and our light field looks that small, you have to remember that you're going to have that beam divergence, that once it gets here, it's still going to expose 17 inches of anatomy. It just doesn't look like it. So you have to trust the process. Because otherwise, if you open up your collimator more, you're ending up overexposing and just creating scatter, because now we're just sending x-rays everywhere willy-nilly. So once you have this set to the size of your image receptor, don't ever go any bigger, okay? All right, so those are the humerus views, all of them, but for practicum, just AP and lateral, okay? Or PA lateral, whatever you wanna do. Moving on to the shoulder, I'm gonna swap out my image receptor here. So shoulder, we're going down to a 10 by 12. And for the first two views for the internal and external, we're going to use crosswise, right? Because we're looking at a wide body part. We want to see all the way from that SC joints, the sternoclavicular joint, out to the lateral portion of the humerus, okay? So it's wider than it is tall. So I'm gonna get my little shelf doodad. And if we want it to be 10 inches, we're going to line this up with the line above the number 10. Okay, so there's little notches, stick them in, flip it down. And then again, you hold this in here, not tight because it's going to slide, but just so it doesn't fall out on the floor, okay? So, I'm going to be 10 top to bottom, 12 side to side. For a shoulder, you're not really gonna collimate. You're gonna leave it at this 10 by 12, okay? So once you're set there, you can just leave it. This drives me nuts. Okay. So I'm gonna come up higher because our shoulder is higher than our humerus. And our centering for our shoulder is 1 inch below the coracoid process, okay? So the coracoid, if you find your humeral head, it sits kind of medial to that. Like James was talking about in class today, it is kind of a tender spot. If you're having a hard time finding that, you can also find your AC joint, which is here at the end of your clavicle. Just follow that over. And you can go about 2 inches below the AC joint, okay? And that's also in line with the top of like the armpit crease. So armpit crease, 1 inch below the coracoid, 2 inches below AC joint. Textbook though says 1 inch below coracoid. All right. So Lauren, go ahead and put your back against the board for me again. And take a step to the left for me. Perfect. I'm gonna come higher. And I'm gonna poke on you a little. So her coracoid's right about there. I went too high. Now, I want you to note that I'm in line with 1 inch below the coracoid, but I'm a little more medial because we want to see all of that clavicle. So the medial portion of my light field is there at that jugular notch or at the mid sternum, and then we're seeing outward, okay? So this is how most clinics are going to have you do it. Just know that by the textbook, it's 1 inch below the coracoid. So we're in that line, but we're just a little medial to that, okay? So we're seeing all of the girdle. So I'm lined up, I'm centered good, and now I'm gonna have her turn her hand so her palm is out. This is an external rotation. We're making our arms wider. So in external, we see the greater tubercle, all right? That's the goal here, is to see that greater tubercle. And I would have her hold her breath, take my x-ray, and then from here, I'm gonna go to internal. So you're gonna turn your arm so that the back of your hand is on your hip. You can bend a little bit, just make sure your shoulder doesn't come way up. And then nothing else changes. You literally go from external to internal and take your x-ray. When we come internal, we're turning the arm over and now we're seeing the lesser tubercle here on the medial portion of the humeral head, okay? So external is greater, internal is lesser tubercle, okay? And then the third view, well, those are our first two for the practicum. I'm gonna talk about a couple more and then we'll do the last one for practicum, okay? So the neutral shoulder, she would just put her arm flat with the palm against the leg. Again, nothing else changes. That's a neutral rotation shoulder. This is for dislocation or patients in a lot of pain. They come in and you're like, okay, what's going on? I'm gonna take this first picture. You like migrated this way a little bit. You would take this first picture just to see what's going on. And then as the tech, you kind of make the call at that point of like, okay, it is super fractured or it is dislocated. So I'm not gonna do internal and external. I'm gonna move straight to the scapular Y. Or I don't see anything crazy, so we can continue with our regular images, okay? And then the Gracie view, which is our true AP of the shoulder, is going to be 35 to 45 degrees of rotation of my patient. So what you're gonna do with this view, if you feel on your shoulder, you can feel your humeral head. Just medial to your humeral head is a soft spot. You feel that? That's your shoulder joint, okay? So you're going to, not aggressively, but lightly grab around the side of your patient's humeral head, find that soft spot, and that's what we're gonna rotate our patient until you can imagine that your beam is coming straight through that joint to the image receptor, okay? That's why it's the true AP, because we get that glenoid cavity nice and stacked on top of itself, so we can actually see through that joint, like you can slide a piece of paper through it, okay? So find that humeral head, find the soft spot, and envision your line coming straight through. Our centering at this point becomes straight on that joint. So I'm gonna come up a little bit, and scooch this way a little bit, and then we can collimate way down too, okay? Come up a little. So that is the Gracie method. You're gonna see this for arthritis, chronic pain, things like that, where they're trying to see if there's something wrong with that joint. Is it impinged on a nerve? Is there bone spurs growing in there? Things like that, okay? So you will do this one commonly, we won't do it for practicum though. So it's 35 to 45 degrees of rotation until you can envision you're going straight through that joint, okay? Let's see. Next week we'll go over the Lawrence method. We're not gonna do that this week. So far for practicum, external, internal. Same position as the humerus, AP, and lateral, right? It's just where we're centering. So our last view for practicum, which is the scapular Y, I'm going to show you on Lauren's left shoulder because that's easier to see. But when you're doing it for practicum, make sure you do the side that you started with. So if you started with your right shoulder, finish with your right shoulder when she turns PA, okay? So for the scapular Y, we are looking for humeral head dislocation, anteriorly or posteriorly. We want our patient to just bring their hand onto their belly and she's going to turn around for me. We're going to do it PA. And what you need to do here, first of all, what you need to do is we have to change our image receptor to be lengthwise, because now we're looking at the length of the scapula versus the width of the shoulder girdle. Okay, so lengthwise, it still is 10 by 12, but it just goes long instead of wide, okay? So then we adjust here and put ourselves at 10 side to side, 12 top to bottom, so that we're the biggest we can be. We can always collimate in, but we want to be as big as we can. Bring your arm across your stomach, and then I'm going to feel and I'm going to find the vertebral border of her scapula, or the medial border of her scapula. If you're having a hard time finding it, you can have your patient bring their hand behind their back to kind of pop the shoulder out, but hers is right there. And then we want to find the inferior angle as well, so that's here. So I need to come down because we want to center between the two, okay? Now, our rotation is between 45 and 60 degrees for this view. So I'm gonna have my patient go ahead and turn part of the way. You can keep your hand like on your stomach or bring it a little lower even. There you go. And then I'm going to put my hand flat on her back, on that scapula, okay? And then I'm going to rotate her until my fingers are straight with the image receptor, because we want that scapula perpendicular with the IR, okay? Parallel with the tube. So my fingers are here coming straight through. I'm centered on that vertebral border. I can collimate side to side. Oops. I'm gonna leave it open top to bottom, but then I'm gonna bring this down to line it up. So she's against, are you against the image receptor? There you go. Against the image receptor. I'm nice and straight right there. And I would throw a left marker up here, okay? Does everyone see that? I'm gonna move your ponytail. So that's kind of your collimation. You're centered on that border and you're coming through like that, okay?